Starting. Hello and good afternoon, everyone. This is Dr. Aparna this side from KIMS Cuddles, Kondapur, and glad to be talking to you today on an interesting aspect of ventilation, volume targeted ventilation. In this presentation, we shall be discussing the pros and cons of pressure control versus volume controlled ventilation. So we'll discuss why volume ventilation became popular. And what were the technical challenges that posed a challenge for implementing volume ventilation in newborns, and how these challenges were overcome. We shall also be discussing some practical pros and cons of volume limited versus pressure limited ventilation, and whether there is enough physiological rationale for changing our practice. Finally, last but not the least, we shall be discussing about evidence for whether there is enough evidence in favor of volume ventilation for making change. Before we proceed, my acknowledgement for my teachers, Dr. Jiva Shankar sir and Dr. Dirari sir, from whom I have borrowed some slides for this presentation. Now we'll discuss the first aspect, why volume ventilation. Now, what does volume ventilation essentially mean? Volume ventilation refers to a set of ventilatory modes where one targets to deliver a constant preset tidal volume instead of a constant preset peak inspiratory pressure with each ventilated breath. So the limiting variable that limits the peak flow in each breath is tidal volume, in contrast to the peak inflation pressure in typical pressure control modes of ventilation. So this is now becoming a norm in adults and pediatric ventilation, whereas in newborn ventilation, we shall be discussing why this was earlier considered to be challenging. So let us understand pressure limited ventilation first by looking at a classical PV loop that you see in any mode of pressure control ventilation, let us say in SIMV. So we deliver a constant preset peak inflation pressure. So there is a certain tidal volume that is generated in every breath that depends upon the compliance of the patient. Now, when the compliance of the patient improves, we may get more or greater tidal volume for the same peak inflation pressure. Whereas when compliance decreases, like in respiratory distress syndrome, or in a baby with stiff lungs with pneumonia, the tidal volume delivered in each breath is going to become lesser. So the tidal volume keeps varying with changing compliance despite giving the same peak inflation pressure in all pressure control modes of ventilation. Now in newborn physiology, we do encounter conditions where there are rapid changes in compliance. For example, in RDS post-surfactant therapy, or when there are rapid changes in functional residual capacity. For example, when the lungs get optimally recruited, we know that the FRC increases and compliance of the lung is FRC dependent. Hence, rapid changes in FRC will also influence the compliance. So for the same or the fixed PIP that we are delivering, there may be rapid changes in the tidal volume based on changes in compliance. This can also happen when there is rapid clearance of lung fluid. For example, if you're given a dose of Lasix or furosemide in a newborn with pulmonary edema, there may be rapid clearance of lung fluid, again leading to rapid changes in compliance. In contrast, when we limit or control the tidal volume in each breath, we fix that X ml of volume is what we are targeting to deliver in every breath. And based on the compliance, the baby may require either a lower PIP or a higher PIP in order to achieve the same tidal volume. So this is how the PV loop is going to look in volume limited ventilation, where tidal volume is constant. And what changes is the peak pressure that is required for generating the tidal volume. So we achieve constant tidal volume irrespective of changes in compliance. Now, you might wonder, what is the difference in achieving a constant tidal volume versus achieving the constant peak inflation pressure? So the understanding that volutrauma is possibly much more hazardous than barotrauma came quite early with a very classical study published by Dreyfus and colleagues in 1988, where they compared 3 groups of rodents who were ventilated. In the first group, which is indicated by the dark orange or red bars, The rodents were ventilated with high peak pressures of 45 centimeters of water and correspondingly high tidal volumes also. So they were exposed to both barotrauma and volutrauma. The second group, indicated by the light yellow bars, got exposed to negative pressure ventilation. You might have seen closed vacuum chambers where even adults in very conventional literature, they describe that negative pressure ventilation was possible, but this is very, very cumbersome. So here, instead of exposing the patient to very high peak pressures, negative pressure is used to move the chest wall and the lungs during inspiration and expiration. Hence, the patient is not exposed to barotrauma. However, they were exposed to high tidal volumes. So that is the second group of rodents indicated by the light yellow bar. The third bar, colored in light blue, were exposed to high pressure, but the chest and the abdomen were strapped tightly so that they were exposed only to low tidal volumes. So this group was exposed to barotrauma, but not to volutrauma. Now, when the researchers compared the markers of lung injury, like the volume of water that had percolated in the interstitial space per unit of kilogram of the birth weight in ml per kg, and also the percentage of albumin that was detected in the interstitial space, which is also a marker of lung injury. All these markers were found to be very favorable in the group that was exposed to high pressure but low volume. So what this indicated was barotrauma as well as volutrauma seem to be equally injurious, or probably when the patient exposed only to high pressure but not to high tidal volume, they seem to be protected from lung injury, indicating that volutrauma probably is more hazardous than barotrauma. So there was interest in volume targeting even in newborns because of all this literature showing that volutrauma is potentially hazardous, and regulating tidal volume in each breath or keeping it constant can actually be lung protective. However, there were technical challenges in volume ventilation. For one, newborns were ventilated with extremely small tidal volumes, which were difficult to measure using the conventional microprocessors that came with the older generation flow sensors. So for example, if you are ventilating a 600-gram newborn and you want to target a tidal volume of 5 ml per kg, the volume that needs to be delivered in each breath is going to be 3 ml. So this is very difficult to measure in conventional flow sensors, which may not be precise enough to measure volume in decimal digits, like 0.1, 0.2 ml. The other technical pitfall was that newborn ventilation was usually done with uncuffed endotracheal tubes, which resulted in a lot of peritubal leak. And this led to difficulty in estimating the actual tidal volume that was being delivered into the baby's lungs. However, these technical pitfalls could be overcome by the newer generation better microprocessors with the ability to measure even small tidal volumes to the extent of 0.1 ml of decimal digit. And they could also estimate the leak around the endotracheal tube or peritubal leak by measuring the difference between the inhaled and the exhaled tidal volume. So with this, we could exactly estimate the volume of gas that was used for alveolar ventilation. So for example, if in every breath, the inhaled tidal volume was 5 ml and the exhaled tidal volume was 3.5 ml, this meant that there was 1.5 ml of peritubal leak. And we could also understand that 3.5 ml was the volume of gas that was actually going to the patient's alveoli. The other technical pitfall earlier was that flow sensors conventionally were measuring the tidal volume at the ventilator end. And we all know that there is a lot of volume loss that occurs in the circuit. And this can kind of culminate to a significant extent in newborn where the tidal volumes per se are extremely small. This challenge was overcome by flow sensors which could measure the tidal volume at the Y-piece end of the endotracheal tube. So this eliminates the need to adjust for the volume loss in the circuit. So with all these technological advances, volume ventilation has now become feasible in newborns. But is it enough for us to change completely to volume limited ventilation? So volume limited ventilation is the form of ventilation where the tidal volume is used as the control or the limit variable to regulate the maximum gas flow, unlike pressure. So there are some challenges in adopting the pure form of volume limited ventilation. One is if you look at the pressure scalar in a pressure limited versus volume limited breath, we will find that the rise to peak pressure is relatively slow in a volume limited breath. This is probably because of the stiff lungs or poor compliant lungs. So when you're trying to achieve a certain tidal volume, the low compliance of the lung limits the ability of the rise in tidal volume, especially in the first few milliseconds of inspiration. As we all know, compliance is FRC dependent. So as and when the FRC keeps increasing through the process of inhalation or during the I time, the compliance becomes better and better, and hence there is a subsequent increase in the pressure. So this slow increase to peak pressure could be an issue, especially in babies with low compliant or stiff lungs. The other challenge, which is appreciated in the flow scalar, is a challenge called as flow starvation that you see with volume limited modes of ventilation. So when we use the traditional pressure limited ventilation, when we look at the flow scalar is the graphic that represents flow versus time. So you can see the first half in blue, which represents the flow scalar in pressure limited ventilation, whereas the red colored line represents the flow scalar during inspiration in a volume limited ventilation breath. So in pressure limited breath first, when we take, the flow scalar typically looks like a fin-shaped curve or a decremental flow scalar. Now, how does this flow scalar arise in pressure limited breath? So you take any pressure limited mode of ventilation, let us say SIMV. So supposing we are using a peak pressure of say 20 and positive end expiratory pressure, PEEP of 4. Let us imagine at the end of expiration or at the beginning of inspiration, the alveolar pressure will be at PEEP, which is 4. Now what the ventilator starts delivering now is the PIP, because inspiration has begun. The ventilator's, the proximal airway or at YPs, the pressure that is now being delivered is a PIP, which is 20. So the difference between the pressure in the proximal airway and the alveolus is 20 minus 4, which is 60. So this delta pre or the pressure gradient drives a very rapid inflow of gas during the beginning of inspiration. So the flow rapidly increases, as you can see in the second curve here, because the pressure differential is maximum at the beginning of inspiration. So this drives the maximum of the peak inspiratory flow rate. Now, as we proceed into inspiration more and more, so as the I time during the inspiratory phase, the peak pressure in the alveolar pressure starts increasing gradually from 4 to 8, and then from 8 to 12, and then to 16. So as and when the pressure in the alveoli increases, the pressure gradient starts decreasing. So for example, when alveolar pressure is built up to 16, the airway pressure, which is still at 20, the gradient comes down to 4 centimeters of water. So the flow during inspiration becomes slower and slower until a point is reached where the pressure gradient between the proximal airway and the alveoli is nil. So this culminates in a phase of zero flow during inspiration, which is called as inspiratory hold. This happens because the alveolar pressure exactly approximates the airway pressure. So alveolar pressure is also 20, airway pressure is also 20. 20 minus 20, the difference is 0. So when there is zero difference in pressure, there is going to be zero flow. Hence, there is a phase during the end of inspiration when the alveolar are completely recruited at the PIP. The alveolar pressure has reached the proximal airway pressure, which is PIP, and hence there is no flow and the patient's lung is sort of recruited at this maximal PIP. So this phenomenon is quite typical of a pressure controlled breath. So I'll go back to the previous slide now. So this is quite typical of the pressure controlled breath. And this has a certain advantage in a certain sense because you give maximum flow, inspiratory flow at the beginning of inspiration when the baby actually needs that maximum inspiratory flow. So this gives rise to the decremental or a fin-shaped flow scalar graphic in pressure limited breaths. Whereas in volume limited breaths, this doesn't happen. So because pressure is not the driving variable, pressure is not the controlling variable, it is the tidal volume which is the control variable. The flow during the entire inspiration is fairly constant, giving rise to a plateau-shaped flow scalar. And hence, in a very small baby who has increased respiratory efforts, you may see a phenomenon called as flow starvation happening during volume limited ventilation. But what we do know is the pressure PV loop in volume limited ventilation ensures that the tidal volume is preset, is fixed, and only the PIP that is required for generating this tidal volume varies based on the compliance. But again, this may come with a problem. When the baby's compliance becomes very low, we may end up seeing that the PIP that is required to reach the same tidal volume might be very high. So if you don't have any control over the peak pressure, again, that might lead to increased barotrauma. For example, let us say you are using a tidal volume of 5 ml for ventilating a extremely preterm baby of say 1000 grams weight. Now, there was some problem, say the baby had suddenly developed air leak and the baby is unable to reach this tidal volume because of the tension pneumothorax or air accumulating in the pleural cavity. So the ventilator, of course, starts alarming that we are unable to reach the set tidal volume of 5 ml. But if you do not have a PIP control knob or a PIP max setting, the PIP that is required for generating or for reaching this tidal volume will go as high as maybe 25 or 28 centimeters of water to reach this tidal volume. And this is not something that we may be comfortable with. So these are all some challenges in the typical volume limited ventilation. It has a pressure scalar that is associated with a gradual increase to peak pressure. And there may be a problem of flow starvation because of the plateau pressure during inspiration, plateau flow that is reached throughout the inspiration, unlike the fin-shaped flow scalar in a pressure-controlled breath. And thirdly, you may have the problem of losing control over the peak pressure entirely. And hence, pure volume control ventilation is not preferred in most of the units. The preferred mode of ventilation is volume targeted ventilation, which is a kind of hybrid mode between pressure controlled and volume controlled ventilation. So what does this term mean? Volume targeted ventilation refers to a group of modes where every breath is essentially a pressure limited ventilation, but you adjust the inspiratory pressure or the inspiratory time in order to target a set tidal volume. So every breath is essentially a pressure limited breath, but we can adjust the PIP of the breath or I time of the breath to adjust to target the set tidal volume. So you kind of achieve the advantages of both volume controlled and pressure controlled ventilation in a certain way. You have a certain control over pressure and you're also able to target the tidal volume. So let's see how the practical algorithms of some of the common modes of VTV function. So some of the common modes of volume targeted ventilation include volume guarantee, which is available with Draeger. PRVC is pressure regulated volume control mode that is available with Servo-I. Volume assured pressure support is a mode that is available with VIP birth. There are some other modes such as TTV or targeted tidal volume, which is available with SLE 6000 GE's ventilator, and volume limit, which is available with Sophie Stephanie ventilator. So we cannot discuss all of them in detail, but we'll at least discuss volume guarantee and PRVC. So in volume guarantee, which is one of the most popular modes of volume targeted ventilation in newborns and available with Draeger, which is a German ventilator, this mode adjusts the inspiratory pressure based on the exhale tidal volume of the previous breath. Whereas PRVC, which is kind of similar to volume guarantee, adjusts the inspiratory pressure based on the inspired volume, not the exhaled volume, the inhaled volume, tidal volume of the previous 4 breaths. So it works on a moving average of tidal volumes of the 4 previous breaths and not only the 1 previous breath, which is taken by volume guarantee. VAPS, on the other hand, manages to do a intra-breath adjustment of tidal volume, wherein the I time of the breath is adjusted in order to reach the target tidal volume. So if the tidal volume is not reached within the I time that is already done, what VAPS would do is to prolong the I time until the tidal volume is actually achieved. Whereas in TTV, the rise time of pressure waveform is adjusted to target the tidal volume. Volume limit is slightly different from these modes. In volume limit, the device terminates the inspiration if tidal volume set is exceeded. So each of them have their own features. Some can compensate for both high tidal volume versus low tidal volume, whereas some can only adjust for low tidal volume. And some target exhaled, whereas others target inhaled tidal volume. We'll discuss the small differences in the coming slides. Now, volume guarantee, which we will take first, is not a standalone mode. It has to be combined with SIMV or assist control or pressure support ventilation. So it has to be combined with one of these modes. So you can have SIMV with VG or assist control with VG or PSV with VG. So in volume guarantee, like in all the volume targeted modes, every breath is a pressure controlled mode, and it can be either time or flow cycle based on whether it is SIMV or PSV. For example, SIMV will be time cycled and PSV is going to be flow cycle. So change from inspiration to expiration is either time based or flow based, and a certain tidal volume is targeted in each breath. This tidal volume is decided by us, by the physician. You also can set a Pmax to limit the peak inflation pressure. So although we don't decide the PIP of every breath, we allow that to be decided by the compliance of the baby as assessed from the exhale tidal volume of the previous breath. But we can still decide the Pmax or the maximum PIP that we can permit. All other parameters are going to be the same. So if you're using SIMV with VG, you will still have to set the PEEP, the I time, the respiratory rate, the FiO2, and if you are working on a ventilator like Draeger, you will also be setting the flow. So volume guarantee generally uses the exhale tidal volume to adjust the PIP of the upcoming breath. If the tidal volume at any point crosses 130% of the set tidal volume, inspiration is abruptly terminated. So the exhalation, the expiratory valve of the ventilator would open, and the flow is just released, and the rest of the breath is terminated at any point of time if the tidal volume crosses 130%. So for example, if you are using a set tidal volume of 10 ml, the tidal volume has already crossed 13 ml, then the adjustment doesn't wait until the next breath. In the same breath itself, the inspiration would be terminated, the expiratory valve will open, the ventilator will cycle to expiration. Now, what happens if the tidal volume is low? If tidal volume is low or lesser than the targeted tidal volume, the ventilator will increase the PIP of the next breath. And this increase at one point will be only a maximum of 3 centimeters of water. For example, if tidal volume kind of targeted was 10 ml and the tidal volume reached in this breath was only 8 ml, the PIP in the current breath, let's say, was 15 centimeters of water. And as per the compliance calculated, we need a PIP of say 19. Still, the ventilator will only increase PIP from 15 to 18 centimeters of water. Subsequent increase will be done in the next breath if the tidal volume is still low. The other thing is the volume guarantee algorithm works separately for the control breaths and for the assist breaths. So as you all know, in SIMV, we have few mandatory breaths, and few breaths would be patient-triggered breaths, which are assisted breaths. So if the patient has reached a certain tidal volume in a controlled breath in SIMV, where the baby did not trigger the breath, it was completely a mandatory ventilator breath. The adjustment based on the exhaled volume of this breath will only apply in the PIP of the next controlled breath and not in the immediate next breath, especially if it were an assisted breath. So this might mean that adjustment in the PIP to reach the same tidal volume might only occur every third or sometimes even every fourth breath. Now, the concept of using exhale tidal volume also is based on this concept that leak during inspiration, as represented in the first figure here, wherein the trachea is more dilated, the larynx is more dilated. Not sure whether it is very clear in this diagram. So generally, because of the higher flow rates that come with inspiration and the thorax, the chest wall, and the diaphragm, all these muscles contracting in order to dilate the chest wall and the cavity, the trachea and the airway is going to be more dilated during inspiration. Hence, the endotracheal tube's diameter being constant, the peritubal leak will be more during inspiration. Whereas in expiration, there is always a passive recoil of the chest wall and the diaphragm, and hence the airway also becomes narrower, including the larger airways, the primary bronchi, the trachea, and the larynx. Hence, there would be the endotracheal tube size being constant, there would be less peritubal leak during expiration. So based on this concept, the volume guarantee proponents believe that using the exhaled tidal volume is possibly more representative of the tidal volume that actually reaches the baby's alveoli and was effective for the ventilation. So one of the key elements of volume guarantee is a concept called as auto-weaning, wherein the PIP is automatically weaned off when the compliance of the lung improves, and we do not have to actually titrate the PIP based on the tidal volumes that are delivered. So this is automatically done by us by the VG algorithm. Also, considering that control breaths and the assist breaths are dealt separately with the volume guarantee algorithm, it actually makes more sense to use volume guarantee with assist control, where all the breaths of the baby which are crossing the trigger threshold are supported or assisted by the ventilator, wherein the breath to breath adjustment will follow every breath. So there would be adjustment which is done in the immediate next breath based on the tidal volume of the previous breath. And hence, volume guarantee combined with assist control offers much more stability in the tidal volume and the minute ventilation when compared to volume guarantee combined with SIM. But volume guarantee, although it seems to be almost perfect, also has some challenges. Now, what are these challenges? One is, we know that whenever we are dealing with a baby who is not sedated and who is having spontaneous respiratory drive, the changes in the tidal volume will not only depend upon the peak pressure that the ventilator delivers, but also on the baby's own spontaneous efforts or the negative inspiratory pressure generated by the baby's own efforts. So when there are rapid changes in the baby's spontaneous inspiratory drive, there can be a lot of fluctuations in the tidal volume generated and in the PIP required in the next breath. For example, if the baby herself had a very strong negative inspiratory pressure generated during a certain breath, the PIP that was required for the next breath may come down very low. Sometimes you may see numbers like 7, 8 centimeters PIP that we generally do not use even in pressure control modes of ventilation. But this may not be the case in a subsequent breath where the baby did not generate enough spontaneous inspiratory drive. Number two, although we use the term guarantee, volume guarantee mode, as you might have seen, doesn't guarantee or assure that tidal volume is consistently delivered in every breath. This is because intra-breath adjustments are not possible. So you have to wait for the next breath for adjustments in PIP to be done in order to reach the targeted tidal volume. And again, this may or may not happen because of the rapid changes in the compliance, in the spontaneous respiratory drive of the baby. So if you have a target tidal volume of say 8 ml, and during a certain breath, the volume reached was only 6 ml, there is no way that this can be adjusted to and made to 8 ml during the same breath. The only thing that the algorithm does is to increase the PIP in the next breath, that too subject to a maximum of 3 centimeter, hoping to reach the tidal volume of 8 ml in the next breath. The other problem is a concept called as sigh breaths. When babies take very prolonged cycle or prolonged eye time breaths, which can make volume guarantee a little bit more challenging. And another problem, which is called expiratory breaking, wherein the baby's exhalation phase can be broken into various phases. So this can confuse the ventilator as to what is to be considered as the exhale tidal volume. Of course, the type of sensor that we are using during ventilation is important for doing any mode of ventilation. And to do any mode of volume targeted ventilation, we need to actually use a flow sensor. A flow sensor can either be in the form of a hot wire anemometer, as in Draeger, or a differential variable orifice flow sensor or pneumotachometer, which is available with some other ventilators like Sophie. But you need a flow sensor in order to do volume targeted ventilation, because we cannot measure the tidal volume with the other types of trigger sensors like thoracic impedance meter, abdomen motion sensors, or Grasby capsule, etc. Even pressure transducers, which can be used for doing patient-triggered mode ventilation, cannot be used when you want to do VTV or volume-targeted ventilation because they cannot measure the flow. So these are the different types of flow sensors which can measure the tidal volume. And finally, when it comes to evidence in volume-targeted ventilation, there is evidence that use of volume-targeted modes reduces the duration of ventilation by 1.4 days and also lowers some other adverse outcomes like air leaks, pneumothorax, pulmonary interstitial emphysema, and lower the risk of developing hypocapnia, CO2 washout, periventricular leukomalacia, and severe grades of IVH, and altogether a significant reduction in the combined outcome of death and BPD. So this is the forest plot from the Cochrane review comparing volume targeted versus pressure limited modes of ventilation, which show that there is a 27% reduction in the combined outcome of death or BPD and 54% reduction in pneumothorax. Now, some practical tips for using volume guarantee mode of ventilation. Try to target a tidal volume which is between 4 to 6 ml per kg. Although physiologically we say that the normal tidal volume is 5 to 8 ml per kg, in most ventilated newborns, we would only target a tidal volume of 4 to 6. And remember that smaller the birth weight of the baby, we may have to set a greater tidal volume in terms of ml per kg. For example, 5 to 7 ml per kg might be targeted in a ELBW baby or a ILBW baby. This is because of the relatively higher proportion of tidal volume that is wasted in the dead space. Set a Pmax which is similar to the PIP of conventional ventilation or perhaps 2 to 3 centimeters greater than the working PIP. P and I time as well as rate in FiO2 may have to be set in SIMB, whereas you may not need to set the rate in assist control. You only will have to set a backup rate. So we have to remember that VG is not a standalone mode and we'll have to set the other settings based on the primary parent mode that is being used. So these are all some recommended tidal volume ranges for a baby with birth weight below 700 grams. You may begin with 5 to 6 or maybe go up to 7 ml per kg. It may not be very wise to come down to less than 5 ml per kg in this baby because even at 5 ml per kg, the tidal volume reach would be around 3.5 ml. Whereas in meconium aspiration syndrome with air trapping, we may target a tidal volume of something like 5 to 6 ml per kg. In a baby who is more than 2 weeks postnatal age, we may again have to account for the increased dead space losses and higher expiratory resistance, and hence we may have to use a tidal volume of 6 ml per kg. Now, the Pmax, as we already discussed, might have to be set at least 3 centimeters of water higher than the working pressure. And when we are ready to wean from volume guarantee mode, we would have generally reached a tidal volume of 3 to 4 ml per kg with a minimal peak of 4 centimeters, a respiratory rate of 20 to 30, and a minimal FiO2 requirement below 30 to 40%. Remember that there is no need to reduce PIP because auto weaning happens automatically in volume guarantee mode. Some practical tips include not to use VG when the leak is high, especially more than 30 to 40%. One needs to look for adequate chest rise clinically, irrespective of whether we use volume targeted modes of ventilation, and try to avoid using volume guarantee when you are operating at very low rates in SIMB because the control breaths would be adjusted independently and the assist breaths would be adjusted independently. So this may lead to a lot of oscillations in the tidal volume. And whenever we use volume targeted mode, it is absolutely essential to use an optimally functioning flow sensor. The flow sensor is the heart of VTV and one doesn't work without an optimal flow sensor. Now in VAPS, which is the last mode, I am sorry that the graphic is not coming in. What the ventilator does is to convert a flow cycle breath to time cycle breath in order to reach the tidal volume that is desired, and auto weaning would not be possible. And there is no safety against hyperventilation. There is only safety against hypoventilation, wherein the ventilator will just prolong the I time until the desired tidal volume is reached. PRVC, which is available in Siemens, Servo I, Mackay Servo I, is a time-cycled assist-controlled breath essentially, wherein PIP is regulated by the tidal volume. By the tidal volume of the previous breaths. So with this, I'll kind of close the presentation. Thank you for joining us.